the kind of diseases we are taking care of as pediatricians were largely defined by infectious diseases, things like measles or meningitis, and then by conditions that were often linked to socioeconomic conditions, so problems with malnutrition and carnivorous. And of course, in many parts of the world, these are still the major problems for pediatric healthcare. But the successes that, including people in this room have done, both through public health and control of infections and vaccinations, have really mitigated to what extent these diseases are affecting the children that we're taking care of. So to give you kind of a sense of what's happened is that if we take in 2017, all of the deaths from birth through age 18 for pediatrics from meningococcal meningitis, there are 11 deaths in the United States. In that same time frame, there were more than 120 deaths from spinal muscular atrophy, one of the conditions Russ is going to be talking about today. And so the conditions that we need to be thinking about taking care of and looking forward have now shifted to being these genetic diseases that we never thought we'd really have a handle on. And so I think that the real challenge for pediatrics in the 21st century is going to be diagnosing and curing these genetic diseases. As we're going to hear about today, the first real therapies are now here. They're not just reducing symptoms or simply reducing severity of disease, but they're actually stopping disease and in some cases curing disease. So there's actually multiple examples of things that are coming here and that will be in the clinic this year, last year, next year. So we have compounds for SMA, gene therapy for congenital eye disease, stem cell transplantation for a leukodystrophy called adrenoleukodystrophy, and CAR T-cell therapy for cancer. So these are the kinds of therapies that are all going to be taken care of for the children in the 21st century. And so I'd like to have Russ come forward and tell us what's going on.
Good morning. This is a slow transition on the computer, so let me just get this up. I'm excited to tell you about SMA today. I know some of you have heard this talk before because I've given it in smaller groups more than once to different smaller groups, but really there's just been a radical transformation in the world of SMA, and so I'm going to walk you through where that story came from and hopefully where it's going. I do have some disclosures to give you. I serve on scientific advisory boards for Sarepta and Biogen, and have active clinical trials with a number of different companies that are developing therapies for neuromuscular disease. My primary funding comes from the NIH and some additional funding from Cure SMA. And what I want to do today is just take a few minutes and walk you through what is SMA from a clinical and genetic standpoint, so you know the starting point. And then talk about a couple of different therapies, one of which is approved by the FDA, one of which has IND pending at the FDA right now, and they're both genetic therapies. Talk a little bit about our newborn screening program as well. So SMA is it's a pretty common disorder, and it's really uniquely a disorder of the motor neuron. So those cell bodies that live in the ventral root of the spinal cord and have a project all the way to the muscle, those motor neurons are uniquely susceptible to degeneration in SMA. And that results in muscle weakness. And we'll go through in detail some characteristics and types of SMA, but that leaves cognitive and other functions normal, and that can sometimes mask the progression of disease. It also leaves significant weakness in the respiratory musculature, both the diaphragm and the accessory muscles of respiration, which is the primary cause of morbidity in these disorders. And genetically, SMA is caused by a common deletion in the SMN1 gene of exon 7. So it's a recessive disorder. You have to have two abnormal copies to have the disease, and about 1 in 40 individuals have an abnormality where you're missing exon 7 or both exon 7 and 8. So if you look around the room, probably more than one of us sitting here have this recessive mutation. And that results in about 1 in 10,000 births of individuals with SMA, which is a lot. That absence of SMN1 results in just a non-functional protein because of just missing parts. The protein itself is fairly well characterized in its function as a modulator of RNA splicing and RNA processing, but it's really not clear at all how that relates to a specific vulnerability to motor neurons, and that's an area of active interest, but we really haven't resolved that very well yet. So there's a second gene, SMN2. This gene is a pseudogene that derives from a very old inverted duplication on chromosome 5. And it's identical to SMN1 with one small exception, and that's this single base pair change in exon 7. And that base pair change causes no change in the predicted amino acid sequence of the protein. So if you could transcribe through SMN2, you would have an exact copy of the protein that comes from SM1. But that C to T transition happens in right over top of an exonic splicing enhancer. And what happens is you decrease the normal splicing of exon 7, and ultimately in the mRNA you have no exon 7, which leads to a non-functional protein, right? Except that part of the time, because this is an inefficient process, you get normal splicing. You get a full-length RNA and a normal SMN protein coming out of that SMN2 gene. And so kind of goes to sort of normal logic that if you have more SMN protein, the disease is milder, and that's what happens in SMA. Because we can have multiple copies, and this inverted duplication that was created many years ago creates some instability in that region genetically, and so you have lots of duplications and things within human populations. People generally have 2, 3, or 4 copies, but can have more or even less copies of SMN2, and the number of those copies means I have more of that residual normal SMN transcription, more normal SMN product, right? And that makes for a very different disease state. So those disease states are defined traditionally by the maximal motor function an individual achieves. So type 1 infants, they never achieve independent sitting. And that's just a clinical definition that existed long before we knew the genetics. Type 2 individuals sit independently but never walk, and type 3 achieve independent ambulation at some point. And if you look at how those break down by just how common they are, SMA type 1 is by far the most common. It's about 2/3 of individuals have type 1 SMA. They have onset usually by about 2 months of age, but anywhere up to the first 6 months. They're defined by that lack of normal sitting, and they have early respiratory failure, which results in death usually before age 2 in most of the patients. Type 2 individuals, in contrast, have usually 3 copies of SMN2. They are diagnosed around the time they fail to walk. So these kids get up to 8 or 9 months of age and have really normal development up to that time when they start a developmental regression, which can be quite brisk. Now, these are 20 to 25% of incident cases, but a much larger portion of prevalent cases just because of the high mortality of type 1. Type 3 has a lot more variability to it. These kids ambulate sometimes even into adulthood, but can lose ambulation even in early childhood, so there's a lot more variability there. There is a type 4 SMA, which is an adult onset form, and a type 0 SMA. They're both very rare. Type 0 is there congenitally and is usually not survivable beyond just a few months of life. Just to give you a little bit more careful picture of the different types, this is a picture of a child with type 1 SMA. Typical onset is about 2 months of age, and it's very common that we see kids that are seen 2 months of age for their well-child visit. They've been normal at their 2-week visit, and by the time they get to that 2-month visit, they are profoundly hypotonic and referred to us often immediately from that visit. Like I said, this is 2/3 of cases, of incident cases, but only about 15% of living cases. These kids have diffuse very severe weakness from very early in disease. You can see in the image that the bell-shaped chest is very typical of a type 1 SMA child, and really there's no diagnostic conundrum with SMA for the most part. These kids are very recognizable. If they come to clinic, we can tell within a few minutes that the diagnosis, right? So that's not a problem. You see that bell-shaped chest. That happens because of very severe weakness in the respiratory muscles, those accessory muscles. That results in just very poor growth of the chest wall, and the children have a little bit less involvement of the diaphragm, so they breathe almost entirely out of their diaphragm, which is what creates that problem. These children have tongue fasciculations, which is just a result of denervation, and the muscle gets twitchy when it's denervated. So if you look at their tongue, it has almost, in a type 1 patient, just a ripple to it. That's pretty easy to recognize. By the time they're diagnosed, they usually have severe dysphagia. They're often having silent aspiration and losing weight. They have absent reflux, but again, normal cognitive function. This sometimes delays their time to diagnosis because they seem just like a quiet child who doesn't cause much trouble. These kids usually are type 1 with 2 copies of SMN2, but there's some variability there too that you can have more or less. Individual with type 2 SMA, like I mentioned before, onset usually as they fail to meet milestones that lead to walking. There are 20 to 30% of cases they sit independently but never walk. They can stand with support, but often lose that very quickly. The weakness is proximal. They often, and this is just a little clinical pearl, they often have a so-called tremor. And if you watch that tremor, it's not really a tremor in a neurological sense, because tremors oscillate at a frequency. Like if you think of a Parkinson patient with a tremor, right? It just has an oscillation at a frequency. The tremor in SMA child is more random, and if you watch, they just kind of jitter like that. And it's really the equivalent of what we see in a tongue fasciculation. So we have denervation in those small intrinsic muscles of the hand, and the muscles get twitchy and cause that little tremor. It's invariable in kids with type 2 SMA, and it makes it easy to diagnose in the clinic because we look at them, they have weakness at the right time frame, and they have that little tremor and tongue fasciculation, so it's just really not that difficult. These kids can have severe disability with progressive scoliosis, progressive weakness over time, but can have a fairly normal lifespan, and I'll show you some data on that. So type 3 are far more variable, and these children have normal early development. They walk usually at normal time frame. Often they'll have onset in early childhood, but can have onset in later years too, even in the teens. I think the latest type 3 that I know was probably 10 or 12 by the time we diagnosed them. The symptoms can be a little bit suggestive of something like Duchenne muscular dystrophy, and we've had several cases that presented to us in about that 4 to 5 year old time frame that we normally see Duchenne kids come in, and they have a Gower sign, and so that really looks a lot like Duchenne because of the proximal weakness. One characteristic feature that's not present in other muscular dystrophies is quadriceps atrophy. So if you look at that child and they have really severe wasting in their quads and that proximal muscle weakness, probably SMA rather than something like Duchenne muscular dystrophy. These kids also have that same tremor that the type 2 kids have, so that, again, makes it fairly easy from a diagnostic standpoint. Just a little bit about the physiology. What we see in SMA is ultimately a loss of motor neurons, and we can detect that using a nerve conduction study. And these are data that were collected from patients here in Utah by Dr. Kathy Swoboda when she was here. And what she was interested in is what's the natural progression of that loss of motor neurons is reflected in a nerve conduction test. So the way that test is performed, we have an electrical stimulator in the wrist and a sensor lower in the hand, and we just shock the ulnar nerve and detect how much of a signal gets through, and that's a CMAP, or compound motor action potential. And what you're seeing in the chart is children who are pre-symptomatic in the open little squares, and children who are symptomatic in the closed squares. And what you see is that at birth, or at that pre-symptomatic phase, they have normal CMAPs, but very quickly they lose almost completely the signal. If you look at type 2 individuals, they have fairly similar course, but it's prolonged. So you have normal findings early on, and then a rapid loss of motor neurons later. And type 3's same sort of trajectory, but stretched out over a much longer period of time. And kind of summarizing that, what you see in SMA is a catastrophic loss of motor neurons in the first weeks of life in type 1 patients. You see a similar catastrophic loss in type 2 patients, just instead of at 6 to 8 weeks of life, it's at 6 to 8 months of life. And in type 3, it's much more variable and can actually have periods where it's more steady. Quick word on mortality. I think I mentioned this. Most children with type 2 SMA don't survive their second year. It's about 95% of individuals who die mostly from respiratory complications. Type 2 kids, however, can have a normal lifespan. They can have significant disability, including susceptibility to respiratory infections, so their mortality is not quite normal. But type 3 individuals have basically a normal lifespan. So sort of nature's message to us that you can treat SMA. All you need to do is turn up the juice on the SMN2 gene, right? If I could just get a little more production out of that gene. And over the years, people tried a lot of different ways to do that, and with ways to open up the DNA with different types of HDAC inhibitors and things. None of those really worked particularly well, and we're not going to spend too much time on the data for that. But the treatment, nusinersen was approved by the FDA a couple years ago, and I'll walk through that because that one seems to work really well. This talk usually ended somewhere around here and moved into a talk about supportive care, right? So before 2016, we talked about nutrition and respiratory care and orthopedic care and how to manage all of those things. We talked about a change over really the last 15 or 20 years from a really palliative care model to a more reactive care model to a more proactive model where we were starting BiPAP early and feeding tubes early before problems had. And we had some real successes with that transition, but none of those really treated the fundamental problem, that the muscle weakness that caused things in the first place. So everything changed December 23rd, 2016, and we knew this was coming. And we heard through the grapevine it would be December 23rd, which was a Friday before Christmas. And we said, that's never going to happen. It's too early. And then it did. So we threw out everything we knew about SMA at that point. And that's what we're going to show you now. It's just everything up to now we've told you is the old way of thinking about SMA. And that whole paradigm even of type 1, type 2, and type 3 is becoming obsolete because people don't meet that benchmark clinical milestone of not sitting, not walking, et cetera. So what is nusinersen? Nusinersen is an antisense oligonucleotide, so it's basically a small piece of RNA. It got FDA approval for all types of SMA and all ages of SMA in December 2016. Side effects are mostly due to the delivery, which is intrathecal, so headache, things like that are common, back pain that are common with spinal tap are common side effects of Spinraza. It's a very targeted medicine though, so it really doesn't in and of itself cause a lot of problems. On the label, you'll see some mention of increased risk for respiratory infection and constipation, but those really aren't particularly significant problems. Also on the label, there's warning about possible thrombocytopenia and renal problems. These really haven't been seen, particularly in Spinraza, but seen in other antisense oligos, not oligos delivered intrathecally, but usually subcutaneously, and those have been a significant problem in those settings. Regardless, the FDA's label suggests getting safety labs for those things prior to every dose. Rash is a thing that we've seen. It's not really in the pre-marketing label, but we've seen it a couple of times in one of our patients, and it's been seen in several others around the country in post-marketing use. And we still don't have a lot of understanding about where that's coming from and how to deal with that. So that's really an emerging thing. So how does nusinersen work? So you remember the SMN2 gene has this C to T transition exon 7. It covers up an exonic splicing enhancer. And what I didn't tell you is that there's an intronic splicing silencer in intron 7. So there's all these little regulatory mechanisms that control the efficiency of splicing. And some very smart person thought, what if we just covered up that splicing inhibitor and see what happens? So nusinersen is a small piece of RNA that targets very specifically a short sequence in intron 7, and it just binds down there on intron 7 and covers up that splicing inhibitor. What that does is it kind of resets the balance of abnormal splicing and shifts it to where you get more normal SMN2 exon 7 splicing, more SMN product, right? So it's a pretty simple concept, and it's very specifically targeted. Since it's a pretty large molecule, right, you just can't give this in some sort of oral fashion, right? It has to go directly into the spinal fluid or can access some motor neurons. The dosing, like I said, it's given through a spinal tap. It's 4 loading doses over 2 months, so it's not just a little bit of spinal taps, it's a lot of spinal taps. And then every 4 months after that, you have to keep giving it. It has a long half-life, so it's only every 4 months, but it does eventually disappear out of the spinal fluid. And that, as the drug was approved, brought up a lot of different concerns, particularly for that group of patients because they're a very medically fragile group of patients, right? They have severe respiratory compromise. Now I'm going to take that child, I'm going to bundle them up to do a spinal tap, which gave us some concerns about safety, and also just the impact of multiple procedures over many, many months was an issue. Scoliosis is just a technical issue that's common in SMA, and how do I give a spinal tap to a child whose spine is either fused or very crooked? The cost, and we can give a whole talk about the cost. $125,000 a dose was created. A huge set of problems and a huge set of issues of how do we address the cost and how do we get approval for the drug, how do we administer this drug in a way that's reasonable within the hospital setting and the finances of the hospital. So there was a lot of challenges. I'm going to just walk through with you the data that supported its FDA approval. And there's really 3 critical trials, 2 of which are randomized trials, one of which is a pre-symptomatic trial. So we'll go through all of those trials and just with a little bit of the data. So the ENDEAR trial is targeting type 1 SMA patients. And there are about 122 kids on this study. They're randomized 2-to-1, treatment to placebo. And that included in kids anywhere up to 6 months old at screening and 7 months old by the time they got their first dose. So some of the kids on this trial were at a pretty late stage of their disease and were profoundly weak. And it's not exactly the same population that we're seeing now with patients that show up at the clinic at 2 months with new onset symptoms. But it'll give you a pretty good sense for the efficacy of the drug. Primary outcome was really the number of individuals that met criteria of full-time ventilation. And by that, they meant at least 16 hours a day for more than 2 weeks on a BiPAP or tracheostomy, or the child expired. There was a number of other secondary outcomes, including motor function tests, which I'll show you some of the data of. So this trial was going along, and with a positive interim analysis in August 2016, the trial was closed because it met early any requirements for efficacy, and all the kids on placebo were transitioned to treatment at that time. So this is just the primary outcome data on the probability of event-free survival, so that event being the full-time ventilation or death. And what you see in blue there is the nusinersen group, and in gray, the control group. And you see that it's not subtle that there's a big difference there in the time to needing respiratory care, to needing full-time ventilation. This is the overall survival. So there was a number of deaths in the treatment group and in the control group. We did have a patient on this trial that made it just into the trial around 7 months of age, and she expired about 3 months later from a respiratory infection. So that group, even on the treatment group, was still at a pretty fragile state. But these data, I think, were compelling in the sense that we delay, if not completely dismiss some of the longer-term respiratory issues. These are the motor data, and what you see is a waterfall plot. So these are all the individuals on this study, and they're ranked by their response. In other words, the Heine-2 is a score for motor milestones. So if you meet a motor milestone, you get a point. If you meet 2 motor milestones, you get 2 points, et cetera. So it's just a scored scale of who met more motor milestones. And again, in blue is kids who were treated, in gray is kids who were on placebo. And you can see that really stacks to the left all the kids in treatment, right? And so they were achieving motor milestones at some level. And the other thing they did, and this is on the bottom of the screen, is, and we always thought this was probably true, that earlier treatment made a significant difference. So they just basically marked with a triangle kids who were treated under 12 weeks of age. So basically the younger kids. What you see is that those marks skew to the left. So the kids who had the higher responses tended to have earlier treatment. And what you see on the bottom row is these are the kids who actually met the respiratory endpoint, and they really skew to the right, so really more toward placebo. So these kids are meeting motor milestones, and they are just very different from basically the natural history, which is the control group. The chair study is really a very similar study. It's about the same number of kids, 126. They're randomized 2-to-1 treatment to placebo. And these kids have onset after 6 months and treated between 2 and 12 years of age. Again, this trial was closed with a positive interim analysis in October of 2016, and all the kids on the placebo were transitioned to treatment. And these are the statistical data, but 5.9 points on a Hammersmith scale different between the 2 groups. I'll just actually show you some of these data. So this is the change in Hammersmith score. And what a Hammersmith score is really a tool designed to assess motor function in older SMA patients. And it scores 0, 2, or 1 on a number of different motor skills. There you can get 64 points, I believe, or 66 points on the total scale. And so you get 0 points if you can't do the task, you get 1 point if you can kind of do it, and you get 2 points if you can do it normally, right? So that's kind of the way to think about that scale. And so what you see is across the course of the study, kids on treatment gained about 4 points. And that means, from a more practical standpoint, is they either fully gained 2 brand new skills or they improved in 4 different areas. And what you can see from the placebo group is that they did make a little bit of gains, maybe at 1 point over the course of that time. It's probably some developmental change, but then they really start to decline, which is the natural history of type 2 SMA. And they really don't gain any points. So a gain of 4 points is actually a pretty clinically significant benefit. What you're looking at here in the second panel is another motor function score, just more focused on the upper limb. And that upper limb score goes up really from the very start in these kids to show significant improvement. So it was clear, from these data that the drug was working, and these led to the approval in 2016. So the other study, and this is an ongoing study, it's not yet published, but it's an open label trial in pre-symptomatic individuals. In most cases, these kids had a sibling who had SMA, so they knew earlier than symptoms started to get testing. And they're treated under 6 weeks of age. They have 2 or 3 copies, so the predicted type 1 or predicted type 2. They're about split even. I think there's 12 and 13 in each group on this study, and really looking mostly at motor outcomes in those kids, with a plan to follow them for at least 5 years. And there is concern that with this drug, there are some systemic effects, and this is an area where we're very interested because we don't really know the natural history of SMA anymore, and what happens when we now treat kids who survive, but we're only treating the CNS, right? We're not really treating anything outside the CNS with nusinersen. So these are the data, and they really are kind of a summary of all the data in type 1 patients. These were presented about a year ago at the Muscular Dystrophy Clinical Conference. And what you see is kind of a summary of all the infant data. So in the orange line is kids on the CS3 study. This is a study, an open label phase 2 trial where they very first started in type 2 kids, and they've stayed on treatment. So we have a little bit longer term, and what we see is they gain points in milestones. So the scale is just attainment of motor milestones. In black is the ENDEAR study, and that's the one I showed you already. In gray is the ENDEAR control group, and this is just the natural history of SMA, right? These kids start out with maybe a few points on those motor milestones, and then they rapidly lose them and never regain them. And what you see in green is the children on the Nurture study treated pre-symptomatically with 3 copies of SMN2. And in essence, within a year or so, they maximize the scale, right? They meet all the milestones. And the kids in blue with 2 copies of SMN2, they make rapid improvements. They don't quite meet the same level as the kids with 3 copies. But you can see that they're very different if we treat pre-symptomatically than their counterparts. Just to give you a little data, so what's happened since 2016? So a little over 2 years since the drug was approved. We have now 28 patients that are being treated with nusinersen. The first one was March of 2017. I'll tell you a little bit more about that individual. 10 of those are type 1, 12 type 2, and 6 type 3. There's a few others in the queue that we're still getting started. 11 of those are new onset patients. I think these are the most critical patients to try to understand because they're the ones that we're treating early that we have the most ability to benefit. And we have 5 type 1s, 4 type 2s, and 2 type 3s. And I'll show you some of the data from those patients as they've progressed along. We also have another 15 patients here in Utah that are part of clinical trials that had been on from when Dr. Swoboda was here. 5 or 6 years now that have been on the early phase 2 trials and have carried forward on treatment now under study protocols. We have a pretty large footprint of patients that are being treated now. We did have one patient who declined treatment. This was early on, and the family felt that they didn't like the over-medicalization of what it meant to have spinal taps 4 times in the first 2 months and continue spinal taps over and over. We have one patient treated pre-symptomatically. I'm going to show you some data from that child. She was treated from 12 days of age. And then just to give you a little sense for how things work in the clinic, we have about 4 to 8 days from the time we first see a child till we can get the drug to them. And that basically requires our whole team to drop everything they're doing and hit it really hard. But what you have to see is that idea of a catastrophic loss of motor neuron really creates a neurogenetics emergency, which never existed before. And every day that we delay results in more permanent loss that we can't fix with nusinersen. So there's obviously been a number of challenges in implementing the nusinersen program. The FDA approval was really for all patients in all ages of SMA, but the data I showed you is the data we had to start with. So we really don't have a lot of data on patients with long-term established disease. We don't have data on adults with SMA. And so we have some emerging data that's coming from clinical experience at different centers, and these really invariably support benefit, even in patients that have long-standing disease. And sometimes those benefits are really hard to measure. Just to give you one example, we have a type 2 SMA patient that we had treated who we try to set up our follow-up something like a clinical trial, but we don't have any of the clinical trial infrastructure to follow them. So we take baseline Hammersmith scores, we take CMAPs, we do all these things that we try to do on clinical trial. And this individual is type 2 SMA. She had never walked. She has pretty severe weakness, but has some remaining arm function. And at the start of the study, and I forget the score, but by 6 months later, so she had gotten her 4 loading doses of Spinraza or of nusinersen, and then was just before her first maintenance dose. And so she scored 1 point better on a Hammersmith scale, which is maybe not that much. And we asked her, well, how are you doing? And she said, I used to be able to raise my hand over my head, but it took a lot of energy. And now I can just pop my hand up over my head. And she does it. She can just put her hand up over her head, which isn't measurable in our scale. So we're really struggling to understand how to measure some more subtle benefits, because that's actually a big deal, right? That I have more fluidity of those movements. And she said, I used to be able to drink from a cup, but I had to do it with a straw, and I had to count 20 seconds, because if I went more than 20 seconds, I would spill the cup. But now I can just drink it like normal. So those sort of more practical things, and they're invariable across every patient to some level or other. Other challenges are the just cost and maintenance of authorization, and it takes many, many hours to get through the administrative red tape, and that's largely driven by the difficulties of cost and back and forth with insurance. There's a logistics of delivery that's a real challenge, and the clinical follow-up that's really run like a clinical trial but doesn't have any financial support that you would have in a clinical trial. So in our 28 patients so far, that's 174 spinal taps in the last 2 years. That's way more than I could possibly do myself, so I have a lot of help from my colleagues in the division. The clinical management, and this is an area where we're also very interested in studying, is like, what is the new natural history of SMA? And really nobody knows that yet. And so we have this cohort of type 1 survivors, and we expect that will continue to accumulate type 1 survivors as time goes on. And you think we'll add, on average, 3 to 4 new kids to that pool every year. And we talked about this sort of neurogenetics emergency that already. So these are data from our patients. So these are the first 5 patients that we treated with new onset type 1 SMA. So these are kids mostly showed up in the clinic around 2 months old. The one on top is our pre-symptomatic patient. So this child we knew about before they were born, and gave her first dose at age 12 days. The others are all symptomatic onset, and what you're looking at is a CHOP and 10 score, and this is another just motor function assessment. It's designed for type 1 SMA patients. It scores 0 to 64, so you can see that our pre-symptomatic patient has actually maximized the scale after about a year, and other patients have made significant improvements. So what does that mean? So most of these patients, they land sort of in the mid-40s and kind of can sneak into the 50s on that scale as they get along. All of these patients still have SMA. This is not a cure for symptomatic patient with SMA. They have profound weakness, they have significant dysphagia, they have G-tubes, they have BiPAP support at night. But what does 40 to 50 mean? And really, especially as you come out of the 40s into the 50s on a CHOP and 10 scale, that means I can maintain vertical posture. So I can sit with some independence, maybe with a little bit of support, much less than I would need before. But that means this child can probably drive a power wheelchair, right? They can sit, we can stabilize them in a chair, and they can drive it. And that means more than just anti-gravity in the movement, right? This means like, and especially as you get out of the 40s into the 50s, a child in the 40s might be able to move their arm around, but really barely against gravity. And as they get into the 50s, they have actually functional movement where they can lift an object, for example. So those are really big differences. And the smoothness of those movements is different. So you can see there's pretty significant benefit in every one of those patients that we've taken care of. This is those same 5 patients with measures of motor milestones, so you get more points. On the right there is just the actual milestones that give you points. You can see that get past 3 for a type 1 individual is pretty difficult. So those kids do get up to 3, so where they're actually getting some points for sitting, but they're not going to probably make it to crawling, standing, walking if we're treating them at a symptomatic phase. Again, the top line is an individual treated pre-symptomatically, and we have her scored up to 7 here because that data point is old, and I'll show you some video of her walking here in a minute, but she's now met all of those milestones. These are our new onset patients with type 2 SMA, so 3 copies of SMN2. And we have fewer data points because it's harder to get them all in and followed, but this again is the Hammersmith. And what you can see is probably a couple different messages. The weaker you start out, the less improvement you have. And the earlier you start, the better. So if we start out, at 35 points and we gain 5 or 6 points, that's actually a big functional change. So that's what you're seeing in this top individual. That means I gained 2 brand new skills or improved on 5 different skills. Right? So you just think about how the significance of that is pretty big. Most of the top half of that scale, so it goes up to about 66 points, most of the top half of that scale is things related to ambulation and really bigger gross motor movements. So these kids, if they're treated symptomatically, are going to top out somewhere in there where they won't probably be able to walk or walk well. I can tell you that both of these 2 children are actually now walking as well. Not good walkers, but they can ambulate a few steps if not a little more. So that's the data on our patients. And just maybe to summarize where we're at with treated patients, nusinersen is not a cure for SMA, but it's really revolutionary treatment. And it may be as close as we can get to a cure if we treat pre-symptomatically. The first patient, just to kind of give you an example, and this is probably the worst case scenario for what we'll face going forward with nusinersen. And this is the first patient we treated. We saw her on a Wednesday at 2 months of age and had started the process to get approval for nusinersen. And on Sunday, she was admitted to PICU with RSV. And for a child with SMA in the pre-nusinersen era, that child will not survive that hospitalization in most cases. She spent the next 3 months, and over which time we treated her in the PICU with nusinersen. It took about 6 weeks for her to really get to where she could even come close to being extubated. And then she just showed slow improvement over the next several weeks. Ultimately, she extubated. She weaned BiPAP down to nighttime BiPAP. She's now doing cough assist when asleep. She's almost 2 years old and doing BiPAP when asleep. She's never been hospitalized again after that first 3-month hospitalization. So what can she do now? She can sit when placed. She can roll from side to side. She's not able to sit without support. She does need a little bit of support. She can raise her arm over her head, and she can maintain head control. And one really big deal, and I didn't mention this before, is that she can talk. And type 1 patients never talked, never made a sound, because you just have no breath support to get a sound out through your vocal cords, right? And so this is one of those little unexpected things we found with kids treated with type 1 SMA now, is that they can actually vocalize and communicate, and that's a really significant change. So that's really our worst case scenario, the child who would have never survived that first hospitalization for SMA. So I'm just going to show you some video of now the best case scenario. And this child we treated at 12 days of old with SMA. She had a sister who died at 21 months of age. What you're going to see is video that Dad's taken in the last few weeks at that same age. And if you look online, he's posted this video, a little bit longer version of this video, because he posts every dose that she gets on SMA Dad YouTube channel. And you can see what his other daughter looked like at 21 months and see the comparison here. And what you need to notice is what you don't see. And this child looks pretty normal. I'll point out a couple little things that aren't normal. But this is, the revolution in SMA. And I'm just going to let it play. It's about 1.5 minutes long.
Good job. Put them all on.
Type 1 SMA. You can see that tiny little shake in her hands. She still has that little bit of denervation in her fingers.
Hi. Where are you going?
She walks around. Remember, she's 21 months age, so this is a little bit delayed. She was able to stand with the couch, and now she's going to climb all the way up there. She's going to look at her dad to see if he's watching. Make sure that he gets this on tape because this is amazing. Now she's very happy that she made it.
Good job.
Smile.
Can you clap?
Just started 21 months old, but she's been like this for a while. This is her first steps captured by mom and dad just before Christmas. First independent steps at 20 months old.
Oh, good catch! Yay!
High five.
For where we're at with SMA and what the potential is. And it's just if you've seen a patient with SMA, you know how this is just, this is just transformative. And what we learned and what we could see coming is that early treatment makes a big difference. And so newborn screening has become an important thing for us. And it turns out that the technology to do that has been around for a little while. People have been studying it, and we understand how to do a newborn screen off of a blood spot using a quantitative PCR. The technology actually multiplexes with skid testing, which already exists in most state labs. So the cost to implement a screening program for SMA is actually not all that high because all the technology already exists in most of the labs. That finally led, and as well as a lot of the data, led to approval by the Secretary of Health and Human Services last summer to add SMA to the recommended uniform screening panel. We were a little bit ahead of that here in Utah. We started screening after a couple-year-long process working with the Department of Health. We started screening for SMA in January of 2018. So we've been screening just about a year now. We were the first state to start doing that. In the year since, a couple other states have come on board. I think Wisconsin and New York are definitely up in screening, and I think there might be a couple others that are getting close as well. We did that with a little bit of grant funding from Cure SMA, as well as some really good working relationships that we've developed with the Department of Health. So what have we found? Just to give you a sense of what we expected, these are the number of new cases of SMA that we had each of the last years for the last decade. And you can see it kind of ranges from 1 to 8, but around 3 or 4 is a pretty normal year for us of children born here in the state of Utah. This is just a quick look at what the actual test looks like. It's a real-time PCR, so basically what you're doing is a PCR reaction where you're amplifying this gene, and you can see that it amplifies or it doesn't amplify. So what you see in red is a patient who has the SMN1 gene, and in green, a patient doesn't have the SMN1 gene. It's pretty easy to tell the difference. What it doesn't do is detect carriers, because carriers have one normal copy and one abnormal copy, and we actually don't want to detect carriers, so it's a good test that way, because I want to detect 1 in 40 people on a newborn screen. It doesn't say the copy number of SMN2 that we asked for. So this is the process that happens at the Department of Health. That blood spot comes in, in the first couple of days of life to the Department of Health. They run the first screen. It's either normal or abnormal. it's variable, right? We can't actually know what is type 1, what is type 2, what is type 3. So now we have to talk about what is 2 copy, what is 3 copy, what is 4 copy. And we try to make some predictions on that. And that week following our initial consultation, we perform a number of different motor tests, including a chop and tend and motor milestones, and we do that nerve conduction test. We present a case to the Neurology Therapy Board, which is a board we set up within the hospital to approve cases for treatment. That takes that recommendation at an institutional level to treat rather than out of the treating physicians. And then we seek pre-authorization. And initially, those pre-authorizations took a little time. I think we've worked well with most insurers, day one, to get early and pretty rapid approvals. And the goal to be treating under 21 days. So what have we done so far? We've screened just over 47,000 individuals. A couple of times we have technical difficulties, rescreening, whatever. And in 3 cases, we had an abnormal result that was called out. In 2 cases, those were true SMA cases. We had 1 false positive. And I'll tell you just a little bit about that case, because I don't think it would happen again. Of those 3 cases, both had 3 copies of SMN2, so predicted type 2 SMAs. Both opted not to start nusinersen in lieu of clinical trials. One is on a clinical trial here in Utah and the other one in Colorado. And the false positive case led us to do some optimization work in the lab that I think we would now, if that test arrived at our doorstep, it would not be called out. It happened early in our experience, so within the first month, and I think we were nervous to not call it out with the cost of delay. And these are the data, and probably defer, I want to go into that because I think we're going to run a little bit short on time. There's some probably more important things to tell you about. What we've been talking about up to now is a gene manipulation, right? Nusinersen is a little piece of RNA. It just manipulates the splicing. We have other gene manipulation therapies approved. In Duchenne muscular dystrophy, we have an exon skipping therapy called Atrophy that was approved in also 2016. And then what most people think of when you think about genetic therapies, though, is a gene replacement. I'm going to give you a little bit of data about the upcoming gene therapy, gene replacement therapy that's coming for SMA. To do that sort of therapy, you need a vehicle. So you need a gene or a transgene that you can put into a person, but you also need a vehicle. And that vehicle, I think, has been pretty well worked out now, at least for the disorders that we take care of with a vehicle called AAV, or adeno-associated virus. There's lots of different serotypes of adeno-associated virus. You can target it to whatever kind of thing you want. For us, AAV9 is a really good vehicle because it targets muscle and nerve. So most of the therapies we see in our muscular world are AAV9. It's a slight downfall is it only can package about 4.5 kb of genetic material. So you have to have a small gene. And SMA is really a perfect case for this because it's a small gene. We can target it well. And the way that works is the gene, or the virus, like viruses do, they infect a cell and they get inside the cell and they just dump their genetic payload, right? In this case, instead of having viral genes, you have just the SMN transgene. And what that doesn't integrate into the DNA, it usually forms a small episome, so a little piece of circular DNA in the nucleus. And as far as we know, it just sits there for many, many years and produces its protein in the way it was designed. One little issue that we'll face more and more is that infection with the vehicle creates an immune response to the vehicle, right? So, and an individual could potentially have a natural AAV infection and be immune to the virus. We think that's probably 20 or 30% of people. So how does gene replacement therapy for SMA work? It's a drug called AVXS-101. They just recently gave it a new name, which is some name I can't read or pronounce. It has many letters, and I gave up on it. AVXS-101 is good enough for me, and they'll eventually get a branded name as well. But it's an SMN1 construct packaged in AAV9. It targets neurons. That viral serotype also goes to muscle and liver, so it can create some significant liver inflammation. Shown on the study protocols have been treated with prednisone to try to knock that down. And what you're doing is actually delivering about 10 to the 14 viral particles through an IV infusion when you're doing that. There's a single open label trial that's been done and 15 kids with type 1 SMA or SMA with 2 copies of SMN2. Those data led to a submission to the FDA that was accepted in November with a decision expected sometime before May 30th of this year. We probably expect it sometime in the early to mid-spring. So there's a couple ongoing clinical trials. There's a trial for SMA type 1 patients or kids with 2 copies of SMN2 that fully enrolled over the summer with about 25 kids. And there's a later onset SMA predicted type 2. This is given by a slightly different delivery system. So for the babies, they get it IV, and for the older kids, they get it intrathecally. That study was fully enrolled in the fall of 2018, and just recently that study opened up a few extra slots at a higher dose cohort. So we're probably a couple years away from getting data back on both of those studies. And then there's a pre-symptomatic study for kids with 2 or 3 copies of SMN2 that's just started enrollment over the fall and will probably continue over the next year. It'll also enroll about 25 kids. So really all the data we have comes from this very first study on 15 kids. And this is their primary outcome, which is the survival from event-free from permanent ventilation. So that's 16 hours of BiPAP kind of mark. The first 3 individuals got a slightly lower dose than the next 12 patients, and so they're sort of subsetted there. But what you see is not a single one of those patients met the respiratory endpoint in either cohort, which is very outside the natural history, right? You've seen the natural history. Here is the CHOP INTEND score, so basically the motor function in these kids. And the first 3 kids that were treated, you can see were treated at a little bit later time points, around 6 months of age, and they made some gains, but pretty minimal. Probably because they had lost every motor neuron that was there to treat. The other kids were treated here in cohort 2 at a much earlier time point and made very significant improvements, even from a symptomatic individual. And to the point where, and I don't have the videos for these, but lots of videos out on the internet of these kids walking around and looking pretty normal. So we think this is at least as efficacious as nusinersen. It comes with a single dose ever by IV of the drug, so it's very different in its implementation. And really the message I wanted to kind of end with is that the future of genetic medicine is here. We're already there. We already have genetic medicine for SMA, and we have a better medicine that's coming probably in the next few months. We have a lot of interest in studying these patients because we have these whole new cohorts of natural history that we don't know very much about. We're doing some studies with the UCR group and others to try to understand some of the economic and social impacts of those early implementations of genetic therapies and the implementation of the newborn screening program. So there's really just a lot happening, and this is just the tip of the iceberg. So clinical trials for gene replacement are already started in phase 1 trials for Duchenne muscular dystrophy. We're part of one of those trials here, and I have those patients. Myotubular myopathy, another neuromuscular disorder, in phase 1 trials right now with a drug that looks very, very promising. There's anticipated to start next 1 to 2 years a number of other genetic therapies for neuromuscular phenotypes, including 4 or 5 different types of limb-girdle muscular dystrophy, a couple at least types of Charcot-Marie-Tooth, Pompe disease, and at least 1 or 2 types of congenital muscular dystrophy. These are all coming into phase 1 trials in the next couple of years. So we're there. We're in the world of genetic therapy right now. We can't do that without a lot of help, and so I just wanted to call out a few people, and this slide couldn't capture the whole thing. James Rogers is our nurse in the Pediatric Neurology division who coordinates all the spinal taps and herds the cats into the right place to get dosing and motor function assessments and all those things. Megan Bernatz is a coordinator for that program, and Tara Newcomb is our genetic counselor who is really critical to getting these patients here, getting fast, getting testing done, and moving those things forward. We have our physical therapists who do all those motor function assessments, and they're very specialized tests, which we do on clinical trials. They're not like a thing you can just refer out to PT to do. It takes an army to do the spinal taps for these patients. I have help from, I think, most every member of the Pediatric Neurology division who's done at least 1 or more of those for us, and the CPC and the sedation team have been a critical part of that, as well as interventional radiology. We do have a 4-hour time window from the time that drug is drawn up into the syringe before it expires. So if for some reason we can't get the spinal tap, it's a big emergency because that's $125,000 in your hand, and we got to get it into the kids. So we drop everything we do and we run over to interventional radiology, and they save the day. We have help from the clinical neurosciences, the adult EMG lab, who's been very accommodating to getting patients in and doing their EMG testing. There's a whole part that nobody ever sees of administration and pre-authorization and pharmacy and all these other things that are needed to get that to go on, as well as our research program. So thank you to everyone who helped make this work. And any questions, I'm happy to answer questions.
Any projections as to the cost of gene replacement therapy?
So
This
the
is
question was, are there any projections to the cost for the gene therapy?
Yeah, so there's no official projections. Vexus, the company who makes the gene therapy, did a investor meeting in November where they sort of pitched a $4 million price tag. They said they weren't pitching that, but they were. We won't know that till the FDA approval, but I'm kind of thinking that's going to be where it's at. We won't know till that happens. I think they were testing the waters with that number, and they had done some study to look at the economic impacts of the treatment to make that justification. On.
Just exciting. If I was correctly keeping track, it looked like there were 3 families in the Utah experience that decided not to do this. And at what point does the data get so far that you might no longer ethically allow that option?
So one family decided not to do it. The 2 families that we screened by newborn screen went onto the gene therapy trials. So they're being treated. I can't share their outcomes with you because they're on trials. One of them's not actually here. They're treated at Colorado. So I do actually know how they're doing. And it's not bad. My trial, so I could share that one. The other family was early in the process, so it was April 2017, so just a couple months into when we started. And that family declined. I really struggled with this because I think from my standpoint, I could see the future where that led. That child died about 6 months later from respiratory infection. I shopped it around with a bunch of people that I trust, all of whom agreed that really we didn't have sufficient data at that time to say that wasn't the right decision, although I struggled with it. I think the more data we get, the more difficult that conversation would be to have now.
Russ, thank you very much. I encourage everyone to come up front to talk to us with any more questions, but that's been a great talk.